Okay, we're going to talk about chest tubes this morning. And a chest tube is a tube that is placed in between the ribs and the pleural space in the lungs. It is meant to be there to allow a lung to be reinflated if it has been collapsed, or to allow drainage if we have blood collection, or if we have an empyema, which is an infection of mucus or a some kind of God, see, I wasn't ready for this. Exudate. See, I wasn't ready for this. Pus. Empyema. The location of the chest tube depends on why we're using it. If we have a pneumothorax, we're going to be putting the chest tube up in the upper part of the chest, okay? Because air rises. So it's going to go up here, up into this location. It's going to be second or third intercostal space. If it's going to be a hemothorax or an empyema, where it's going to be lower, it's going to be down here in about the eighth intercostal space, okay? So anything that's fluid is going to be heavy. It's going to drain low. So we need to move our patients around because of that. Patients that are at risk for pneumothorax men are at high risk for pneumothorax, potentially because they are very thin. Their muscle mass ratio is a lot greater than us as women, and they have these growth spurts when they're about 16, 17 years old. And our boys will come in with shortness of breath, and they will have just these spontaneous pneumothoraxes. Okay. Other things that put our patients at risk are smokers. They have an increased risk with the length and the number of cigarettes they smoke per day. Of course, you guys can kind of guess that lung disease might be high on our level there too. And so patients with COPD, breast cancer, or cystic fibrosis. Some of our patients have hereditary problems such as little blebs in their lungs, and these are little air blisters that cause. It's a lot like a cyst that as women get on our ovaries, and these can potentially burst, and we will have them developing a pneumothorax from it. Our biggest problem that we have, though, and our other highest risk is our trauma patients. And so our trauma patients can be any kind of blunt chest injury, can be caused from a high-speed motor vehicle accident, blast injury, falls, or acts of violence. So anybody that wants to take a baseball bat to their friend or whomever, they can take it and beat the shit out of them and give them a pneumothorax here by causing fractured ribs. Okay, so we can have our patients come in with fractured ribs or a flailed chest. So this patient here was probably related to a high-speed MVA, or potentially that person beating them like crazy, just taking a lot of blunt force to the rib cage area. You can see multiple fractured ribs on him, and on the left side of our screen here, you can see where his two chest tubes are in place, one high and one low. So he probably has a hemopneumo. He has a combination of both a punctured lung and blood collection in the chest there. Yes? Flail chest means that when the ribs are completely fractured and you do not, so the question was, what is flail chest? And so when the ribs are fractured and you will see movement of the chest, so normally we see a symmetry of the chest moving up and down. It's when one side of the chest will move up and the other will not. So the side with these grossly fractured ribs will not rise at the same side as the other one. So repair of the chest with a flail chest here is, if you can see on the right side here, you see that we have these wires here, and these little things here are his staples on the outside of him. So that would have been this patient, that would have been the patient over here on the left side. See how badly those ribs are fractured? Normally we will let the ribs heal by themselves. But if they are severely fractured like this, we may have to go in and repair them during surgery. okay, because of the distance that they've been fractured, or if they're multiple fractures of the ribs, 2 or 3 places in one rib, it can still continue to cause damage to the lung. So as those ribs move, they can cause additional damage to the lung there. Okay, tension pneumothorax. This is actually a medical emergency. If you can think of our patient that had that fractured ribs, as long as those are not allowing an exit wound to the outside of the skin, we have what could potentially be a tension pneumothorax. So with our patient that has an exit wound, such as a stab wound or rib that has punctured the muscle, the chest wall, we're actually in a better place than we are if we have a tension pneumothorax. So a tension pneumothorax is considered a medical emergency because if we have that hole in the lung, and you can understand that we have this closed system here, okay? We have no place for the air to go but into the pleural space, okay? So as the patient takes a deep breath in, air escapes that hole and goes into the pleural space, all right? If we don't have any way for that air to come out by putting a chest tube in, it continues to fill the pleural space, causing pressure on the side of the lung that is collapsed. Okay, so eventually it will completely, if you'll look here on the left side, it completely darkens out and you will see the heart, where it should be midline, is off to the right. So it will shift things in the opposite direction. So if our collapse is on the right side, our heart tones, which we would expect to be kind of over the left, maybe under the left axillary area or significantly over to the left side. Same thing opposite. If we had a tension pneumo on the right side, our heart that we would expect to be over our left midclavicular area is going to be maybe substernally. Okay, so as it puts pressure on it, it shifts those great vessels and stuff. And we will have a significant change in our patient. So we can have our patient have vascular collapse very quickly because of the amount of pressure that's put on there, okay? If it continues to leak, we will be having our patient go into cardiac arrest, all right? We do see our patients with this when they come in, or you hear of them being brought in by paramedics with needle decompression, okay? So it just means that the paramedic has put a needle into the pleural space, just taken like an 18 gauge or a 16 gauge IV needle, and has put it in to the chest to allow the air to escape, okay? Then when they get to the hospital, we're ending up putting an emergency chest tube in the patient. Yes?
How long after somebody gets a tension pneumothorax do they normally
become compromised? It depends on how big the hole is. So you will see your patient having significant drop in their blood pressure and significant chest pain if they are awake. But if we have a patient on a ventilator, we're not going to be able to see that. We'll see our ventilator will start alarming, but our patient will start complaining of significant shortness of breath if it's a spontaneous one. Pleural effusion. So I said that we could drain fluid out along with an empyema. Pleural effusion is another thing that we can drain out of our patient. We will have a collection of just a serous type of drainage in the pleural space. A lot of these patients are lung or breast cancer, sometimes with pneumonia or a severely compromised congestive heart failure patient. And you'll see over here, we've got this big circle. This is a pretty good size pleural effusion on our patient. And a lot of times you will take care of patients that have gone down to radiology just to have a needle thoracentesis done. And that's to take out this amount of fluid. Depending on how long it is there or how much is collected in there will depend on whether we're going to do a chest tube or we're going to do a needle decompression on our patient. Our goals for the chest tubes is to remove the fluid or air as quickly as possible. We want to prevent air and fluid from re-entering the chest, and that's why we have these chest tubes. We want to re-expand the lung and restore normal negative interpleural pressure. To drain a hemothorax or a pleural effusion, the chest tube is directed. Remember how I told you guys it's kind of where the location is where we want to pull the fluid from. So it's directed towards the pleural effusion, okay? So it's up in the side of the chest, all right? And it's directed towards that pocket that we have of fluid, okay? Because our chest tubes work by gravity, even though we have suction on this, everybody seems to think that we are going to suck out the stuff that's out of there. That's not how this happens. That's only creating our negative space in there. It is the position that we put our patients in that allows us to promote drainage, okay? And so our big thing that we need to do with our patients is we need to put them in a upright, semi-upright, constantly turning our patients, and our patients often don't want to move, okay? They have this large chest tube put into them, and it's put in usually in an emergency type situation. This is what it looks like coming out. This is one that is a size 32, which would be significant for somebody that has some kind of blood collection in their chest, all right? It is put in with this very nice little introducer, which is very sharp. The physician will put a stab wound into the chest using these large hemostats, open up that space, and then shove this tube into it, okay? This thing, when it's in there, though, is very stiff. Okay, so you can see that your patient's not going to want to move around a lot. They're not going to want to lay on their side with this in. But the way we can help our patient by telling them that they're going to get this out is by causing the drainage to come out of the chest, and we can then see full re-expansion, and we can then eventually take these things out. Okay. Some of the risk from insertion is the tube being moved accidentally. So this can be done because these are only, the only thing that's holding them in is a simple suture that is called a purse string suture. It's one of those sutures that us girls know about because we had little purses that we used to pull real tight, and it used to close the neck of the purse up, okay? That's the only thing that's holding that chest tube in place. As you'll see on there, there's no kind of holes on there that you see like on a triple lumen line that has holes that it can hold a suture on it. Because of where the chest tube goes in, we have no distance of, consistent distance for it to go into. So the purse string suture is there meant for two things. One, it's to hold the suture, hold the chest tube kind of in place, and two, it's used when we take the chest tube out. The other thing that holds the chest tube in place, though, is going to be tape and a dressing. All right. So when we go and secure these, we're going to make sure that we have tape over our dressing site. Okay, and we're going to talk about this when we have this at our bedside. Some of the supplies. So we can cause, inadvertently cause some bleeding with the chest tube insertion and or afterwards if we're not securing this well. Improper placement, so the tube can be forced into the tissues, the abdomen, or too far into the chest. This is not done under radiology. This is all done just by kind of feel. Unless we happen to send somebody to interventional radiology, at that time it's not an emergent type of procedure to be done, and it's usually going to be more of a thinner tube that's going to be put in our patient. Yes?
So why do the surgical patients get chest tubes for like after open heart surgery? Is it for fluid collection mostly?
Good question. Fluid collection, yes. For after open heart surgery, we're looking at fluid collection in the pleural space. So the question was, why do patients get chest tubes after open heart surgery? So we're looking at them having split the mediastinum, and there's fluid collection, serious drainage oozing from the wound, and so we're using it just strictly to drain out that extra collection that's there. So anybody that has had a lung resection, so for a lobectomy, anything like that where we've cracked open the chest and we've got into that pleural space, there can be a collection of fluid oozing from the wound itself. We're going to have that in there. Okay. Okay. So supplies at the bedside, I kind of talked about a couple of them there. So our supplies at the bedside that are going to make sure our dressing is secured and that we have emergency supplies available for us are going to be a new Pleurovac. As you see up here in the front, I have the Pleurovac set out for you guys. But when it comes from sterile processing, it's going to come in a plastic cover like this along with a blue sleeve over it, so this can be used in emergency. So it's got kind of a dust cover over it, the blue one is, so that as they take it out, they can use this in a sterile surgical procedure. Okay, so that's what that dust cover is. You open it up and then you come out with the chest tube that looks like this. We have a bottle of saline that we keep at the bedside. We use that for two reasons. One is we use it to refill our fluid collection chamber here as this evaporates, or we use it in case our patient decides they want to pull out their chest tube. Okay? If they decide they want to pull their chest tube apart and they need to get up and move around and we don't want them to, we want to create this underwater seal again. Okay, we're going to talk about underwater seal in a minute. So we're going to put this chest tube in at least 2 inches of water. Okay, so if you guys can think about what would happen if this was in a patient's chest, open to air, air is going to go in. Okay, we're going to give our patient a pneumothorax. All right, so what we're going to do is we're going to put this in water. So then as the patient breathes, they would have to take such a deep breath in that they suck up all the water into the chest first before they get any air in. Okay? So this creates our underwater seal that we have on our chest tube. You guys have heard about that underwater seal. Right? The other thing that's going to help our dressing site and make sure that we don't get any air into our site is stuff called Vaseline gauze. Okay? The surgeon or you will be responsible for, if you go and change a dressing, of having these supplies. So you want Vaseline gauze because, as I told you, they make a little stab wound and they have this chest tube inserted through that stab wound. There's no way to completely seal that closed because of the diameter of the tube that's going to go into the patient's chest. So we're going to close it up by putting Vaseline gauze around the site. Okay, so it's going to wrap around the chest tube. What do I do with it?
Do you need it?
No, that's okay. I got one here. Thank you. So the Vaseline gauze is going to wrap around the chest tube. So this is going to wrap around this way. So as you guys can see, then that's going to seal up against the skin and it's not going to allow air to come in beside the sides of the chest tube and the skin stab wound. All right? And then we're going to put a split dressing over that. All right? And then we're going to use some kind of occlusive tape, either silk tape or foam tape, something that's going to completely seal on top of that in addition. Okay. So that's why you need your silk tape or some kind of a solid tape there. As a whole, we usually do not change dressings on chest tubes unless we have an order. Okay, we don't do it unless we have a specific order for changing the chest tube dressings. I did have somebody in the last group that said they just changed a chest tube dressing, which is not something, as I say, that we usually do. This is usually done by the physician. Usually when we pull it out, we may have to change the dressing afterwards, but usually we don't do it on a routine basis. Okay. If the chest tube comes apart, okay, we kind of talked about that. So if the chest tube comes apart and our patient is symptomatic, that's when we're going to shove this tube into that bottle of water. You will see your patient having increased anxiety, diaphoresis, increased respiratory rate. We're going to clean the end of the tube and we're going to put it back to our connection here. Okay, we're going to strictly shove that back in here and we're going to retape this. I can't even do it. keep on pulling apart. So we're going to retape this. We're going to call our physician, because we want to call our physician because we want to get another chest x-ray on our patient. We want to see if we gave them, now from having a hemothorax, if we gave them a hemopneumo. Because if we did that, we may have to put an additional chest tube into the patient. Yes?
When you were referring to pulling, when the patient pulled the chest tube out, were you saying they were pulling it from the connection, not
From the
out?
connection here.
Oh, okay.
Yes. Good question, though. Good question, Kat. Because I do need to clarify that with you, and I will in just a second. Okay. So if our patient's not symptomatic, this is where we can put our chest tube into the water, and we can set up a whole new system here. Okay? And so Kat was asking if I was referring to my patient pulling the chest tube apart, or if the patient pulled the chest tube out of themselves. So if the patient, what I was referring to was if the patient pulled the chest tube apart. So if the patient pulls the chest tube physically out of themselves, we need to just slap a dressing on there, and we want to have a 3-sided dressing. All right? We want to be able to allow air to come out of the patient, so we do not use this Vaseline gauze. We use something like this, like just almost solid. This is more solid than what we would do with a regular gauze. This is more of a knit gauze, but we don't want something that has a lot of holes in it, but we want to allow air to still come out. So if a patient has pulled it out, we put a 3-sided dressing on the patient, all right? So that it doesn't allow air to suck in, okay? As they're taking a breath in, they can actually cause themselves to have a larger pneumo.
Just meaning you only tape 3 sides.
Correct. We only tape 3 sides of the dressing. Correct. Okay. So the Plurivac is, we have 2 different kinds. I'm used to using wet and dry. You guys here in San Diego have, we've pretty much changed over to the Atrium chest tubes, which are Ocean and Oasis. So standing for wet ocean, dry oasis, okay? The drainage system consists of 4 different compartments, and it's the same on each of those compartments. So it doesn't matter if it's an oasis or an ocean. All the chambers are going to relate to the same thing. So the A is the suction chamber, okay? So when you hear that your patient is on 20 centimeters of suction, in your wet one, that's pretty obvious to see here. It's right here. The fluid is up to the 20 centimeter mark. Okay, over here on this A, it is a dial of flow. So the physician will request what he wants the drainage set at, and there's a little dial over here on the side that I can change the suction accordingly. Okay, B is the water seal. That's this chamber right here. So B is the water seal. We can see that. And C is the air leak indicator, which are these bubbles that go from 1 to 5 on both sides. And also, this is where I said that we need that 2 centimeters of water, right? So in order to create that water seal, we've got this fluid in here up to the 2 centimeter mark, okay? So you will always see that consistently, all right? When the bubbles are from 1 to 5, that relates to the amount of air escaping the lung into the pleural space, right? So at a 5, we still have a very large hole in the lung. Air is escaping. As we get to a 1, the hole is getting smaller and smaller, okay? And if we have a 0, we either have no hole in there or we have a hemothorax. All right, we have no air leaking, but we have some kind of fluid, empyema, pleural effusion, something like that. We will not see air over here in our leak indicator. And D is the fluid collection chamber. Anytime these become full up to 2,000 or probably 1,900, we're going to change this out, and we're going to put a new canister up. Yes?
So on Oasis, how does that pressure relates to the wall suction? Is it like the same thing, or?
Yes, it is the same thing.
One or the other?
No, it's the same thing. So when we look at where we see whether we have pressure, We are always hooking this up to suction. When we see gentle bubbling over in here, we'll see that. On this one, we will see these little bellows come out to this little diamond area, okay? When we can tell when we have suction applied to our chest tube, okay? So in here, it's, as I say, it's real easy. I can turn this on, but it's gonna make a really loud growling noise for you guys and probably won't be able to really see it. So, but we should see gentle bubbling over here, all right? We don't wanna see it aggressively bubbling because if we do, all we're gonna do is cause evaporation of our fluid, all right? We don't need that. All we need is just gentle bubbling over here. Remember, that's not what's gonna make the chest tube drain. What's gonna make the chest tube drain is by moving our patient from side to side. And if we have fluid or any kind of pus, blood, any kind of accumulation like that, we're going to be able to drain it out by gravity. All right? It's not the amount of suction that's in the air A chamber over here. It is the drainage of the fluid out of there, or the hole has actually sealed up by itself. Some of our patients may, if they have such a significant hole, they may have to go to surgery to have it surgically closed. But most of the time, we can just do it over a period of days.
How do they like decide if they want the wet one or the dry one? Are there different circumstances?
Yes, there is. Usually it's one physician preference, but how large the pneumo is and how much negative pressure we need to cause in the pleural space. Okay, so as we cause more negative pressure in the pleural space, we need a higher thing over here, so you will see the oasis. I've only had a couple patients ever with the oasis. 95% of my patients have always been with the ocean. Okay, and a lot of times you guys will go in the rooms and you will hear these things aggressively bubbling. Not necessary. It's just going to annoy you and more especially the patient because they have to listen to it all night long. All right, so the amount of pressure that we're causing is by the fluid in here, right? Okay, up to 20, there we go. 18, 15, if we want 10. Remember, we can dial it over here. Over here, all we have to do is add or subtract our fluid, right? So when we're checking for that air leak, you'll see here my notes that we say we're gonna check in that C chamber, right here, okay? To locate the leak in the tubing with rubber-tipped hemostats. All right, this is the only time we're going to use our hemostats with our chest tube. All right, so the first thing we're going to do is if we have leaking over here in the chamber, we're going to start by clamping up above. These will normally have rubber tips on them. We won't have these graduated teeth on here. We'll have this, we'll clamp it and see if our bubbling stops. Then our leak is in our patient, okay? If our bubbling continues, we want to go down below any place where we may potentially have a leak. In here, we may get a leak from our connections not being secure, okay? If we do that, then our leak is in here, all right? If we go all the way down and we go down to this place down here and we still have bubbling in it, we may have a crack in our canister, okay? So we'll have to go in and change the canister out, yes. No. It's got a slide clamp on it, but the slide clamp will only work on this rubber part here.
Oh, you can't slide it all the way.
Right, we can't slide it all the way up, yes.
If there is a leak in the tubing, do you just tape it or do you have to change the tubing?
You have to change the tubing.
Okay.
Okay. We want to change, if it's in this part right here, Kat, all we're going to do, the question was if there was a leak in the tubing, do we just tape it? But one thing, there's no way we can really identify exactly where the leak is. So we will make sure we re-secure our connections here and tape here. And we want to make sure that we have that occlusive dressing here around the insertion site, okay? The other thing we want to do is we want to also visually see where our markings are in our chest tubes at the bottom of our dressing. It's kind of like a central line or whatever you do your assessment when you're first looking at your patient. And you have somebody that you're getting out of bed and stuff. You want to make sure your chest tube's in the same place it is when you get them out of bed and when you put them back to bed. Because if these little eyelets right here come out of the skin, out of the chest wall, it can allow air to go in. All right, all of a sudden we have a big bunch of air leaking in here. Okay, so somebody asked before, is it documented somewhere in the chart? not usually as to where the dressing is and stuff. That's just kind of one of those things that you do in your nursing assessment, is go in and look at that. All right. This material can be used to access a specimen if we need to. So if the physician asks for us to send a specimen down to lab, our patient has an empyema or some kind of a potential infection, we can go ahead and use this tubing to get a collection from. It is permeable to, self-sealing is what I want to say. It is self-sealing. So if we go ahead and we stab it with a needle, it will self-seal. So we don't have to worry about covering it with a piece of tape after we have used this. Okay, so assessment of our patient, things that we need to document. We need to document respiratory rate, regularity, depth, and ease of respirations. We need to listen to breath sounds, pay attention to symmetry of sound. Diminished breath sounds on the affected side may indicate reaccumulation of air or fluid in the pleural space. Tubing needs to be inspected for leaks, kinks, and fluid-filled loops. So what we really want to do is we want to make sure that we have our chest tubes in a straight line from our patient to the bed itself. Sometimes these tubes can get kinked if we're moving our patient. It won't get kinked up here so much because this is really stiff. This is like our drainage tube for our Foley. It's very stiff. The patient can lay on this and not compress it. But look at this. They can lay on this and they can compress this tube. Okay? They can compress this rubber tube. When we're moving our patients around, we can cause kinks in this thing. Okay? What we don't want to do, though, is we don't want to make a bunch of dependent loops. So if this is I can't do it because you guys need to see it. So I don't want to have a bunch of loops going down and back up to my chest drainage, okay? Because then this is only going to drain by gravity, all right? That means there's a lot of pressure and a lot of stuff that's got to fill before it gets all the way over here into my container, all right? This is the time that I do want to do loops on the bed, okay? On the bed, not on the floor, anyplace else. I don't want loops down there. I want it on the bed so that it will collect from my patient. On the bed here, you can see that it will be at the level that's at the patient's level, and then it will go directly into my canister. Okay, it doesn't have to go downhill and then back uphill to my canister. Okay, so that can be, we can really promote our patient to getting their chest tube out quicker by making sure that we don't have a bunch of dependent loops. We need to make sure that our canisters are away from the edge of the bed, because if we have a patient on the floor versus a critical care bed, where their beds are always higher than our beds here, these beds go lower to the floor because we're getting our patients out of bed. Okay, we're trying to promote our patients getting out of bed. These chest tubes will fit right underneath those rails of that bed and it will crush them. Okay, so what you'll see sometimes is you will see the chest tube taped to the base of an IV pole. That way you can move it away from the bed, okay, and it still will not get knocked over. All right, these have just two little feet here that kind of keep it balanced. Okay, so changing the canisters necessary when it's full, cracked, or broken. We want to open up the outer cover for it, and we will then loosen the chest tube at what's called the step connector, which is this little one that has these graduated marks here. Okay, I'm going to do this with two people in the room. Okay, if I have to go to the step connector, otherwise the other place that I can do it is down here. On these particular ones has a quick release, and right down here I can leave this all attached to my patient, and I can quick release right here and actually just have a canister available and ready to go and snap it to a new one. I want to have my patient do a Valsalva maneuver while I'm disconnecting and opening this up, because I don't want them sucking in air into their chest.
So you don't clamp when you change the canister, or do you clamp?
You can clamp if your patient is not with it and can do a Valsalva maneuver. Okay. So if there's two of you, you can go ahead and clamp real quick and then go ahead and do this, just depending on how cooperative your patient is. Otherwise, you can clamp for a short period of time and go ahead and change this out. I think if I were doing it by myself, Natalia, and I had to go to the step connector, I would probably go ahead and clamp it, because I'm not going to have enough time to do it in a quick enough manner by myself to do it. So I would clamp it and change it out. Okay. So documentation, if we're helping insert a chest tube, we want to say who inserted it, the size and location of the insertion, drainage amount, color, type, suction amount that we applied. So on the normal patient, you only need approximately 10 to 20 of on your dial, on your suction, on the Plurivac. Okay, on the Oasis, I'm sorry, on the Ocean. On the Oasis, you're going to need a higher suction, all right? Even though it's still set at 20, to make these little bellows come out, I need it dialed up a little bit higher, okay? We're going to document the presence or absence of tidling and bubbling in the water seal. Patient's tolerance, respiratory status, we're going to consistently assess vital signs, color, shortness of breath, dyspnea, O2, and supplemental O2 if they need it. X-ray results. So X-ray results are going to tell us when we can get this chest tube out. We will be doing usually a portable chest X-ray on our patient until our physician tells us we can take our patient off a suction and be able to, one, ambulate him or send him down for an upright chest X-ray. And so what we're looking for our chest X-ray results is we're looking for that accumulation of fluid. We're looking for that darkened area or shadowed area that we saw in the pleural effusion. We're looking for that, for the lung to be fully re-expanded, and we're looking for a decrease in the amount of fluid that's coming out of here. So if the patient's still putting out 50 to 75 milliliters of fluid every 12 hours, we're still probably not going to take the chest tube out until that slowly diminishes, maybe down to 5 or 10, right? If we're looking at a pneumothorax where we have an air collection in there, we're looking at no bubbles in our air chamber over here, and we're looking for the lung to be fully re-expanded. Now, does it mean that if I have an occasional air bubble in here that we're going to not take it out? No. It might be that when the patient coughs or something like that, they can be popping open that little hole that's there. So if it's intermittent or if it's continuous, that's another thing that you guys are going to really want to make sure that you document, okay? So if you have air leaking in your air chamber, is it intermittent or is it continuous leaking? We want to do patient and family teaching. Patient and family teaching, we want to get that patient out of bed. We want to turn them to their side. We want that patient taking medication, usually narcotics, to alleviate the pain enough so that they can do their deep breathing, coughing, and moving around. We want to get that patient out of bed to the chair or to a bedside commode. They're not going to be able to get out and walk in the hall until we have an order for the patient to be off of suction. All right? But we can get that patient out of bed and we can set them in a chair. It doesn't mean that they're immediately only in bed and that's it. Okay, so removing the chest tube, kind of talked about a little bit of what we see when we want to take it out, and we want to have supplies at our bedside, which are going to be the dressing and a occlusive Vaseline gauze, tape, and a just some kind of gauze on there. So Vaseline gauze, the white knit gauze that you guys have, and then tape. And you want to pre-medicate your patient. These are uncomfortable coming out, so the patient's going to come, the physician's going to come in, he's going to whip it out. He's going to pull that purse string suture that he had there. That's going to be the thing that's going to close that stab wound closed that he formed when he pushed the chest tube into the patient. We're going to then, afterwards, we're going to really be documenting our patient's respiratory status, because we may have to put a chest tube back in them if that pneumo has not resolved. That's it, guys. Done. Ta-da!
That was great.
Sorry. I really wasn't prepared for that, Sue. Thanks.
No, you did good.
Yes.
Okay. So back on the Pleurovac slide, you said if you have a 0,
Uh huh.
do we have a hemothorax?